Measuring pain is really important, as mentioned in George's presentations, and it sometimes can be difficult because it is a patient experience, so it's difficult to analyse specifically how much pain they're in. But what I will be discussing is different types of questionnaires that we can use to discuss the type of pain the patient is in, frequency and the intensity they may be experiencing this, to give an idea of what we can use in practice. The first questionnaire I'll be talking about is the Patient-Rated Tennis Elbow Evaluation Questionnaire, and this was done by Romp et al. 2007. The aim of the study was to determine the reliability, validity, and sensitivity of the Patient-Rated Tennis Elbow Evaluation. I will be calling it PRTEE as short for the questionnaire. These results were compared with the results of the Visual Analog Scale and the Disability of the Arm, Shoulder and Hand, which is known for DASH questionnaire, and also the Rolls and Maudsley score and the Upper Extremity Function Scale. Results were completed at baseline and then at 12 weeks, and they specifically focused on patients with lateral elbow tendinopathy. The reliability and internal consistency was excellent, and the correlations were good between the PRTEE subscales and the total scale and the VAS, which is the Visual Analog Scale, and the DASH questionnaire. In addition to the study, Vincent and McDermott 2014 explains this kind of study a bit more further through their own kind of explanation of what the PRTEE questionnaire is. So this questionnaire is a patient-rated 15-item questionnaire to measure the perceived pain and disability in people with tennis elbow. There are 3 subscales, which include pain, usual activities, and specific activities. The pain subscale has 5 items regarding intensity of pain during various activities. Specific activities has 6 items that look into specific activities that the patient finds difficult, and then 4 items into usual roles like work or recreation. And these are based on a scale of 0 to 10, 10 being the worst and 0 being no pain. The patient would rate the pain in the last week, but circling back to their current state. This study shows that this particular questionnaire continues to demonstrate sufficient clinical measurement properties and present with excellent reliability in tennis elbow patients, and actually actual tennis players, because I think they related it back to tennis players as well. It is currently being used in various countries, and they translate this questionnaire to their own language, so it just shows how reliable it is that it's used amongst many researchers in their own studies. And when I was doing my own research on about tennis elbow, a lot of people were using this type of questionnaire to evaluate these different subscales. One good thing that I found about this questionnaire is that if we need to expand a specific area, such as pain or maybe functional elements, we can do this through the VAS, the Visual Analog Scale, so that focuses specifically on pain, or the DASH questionnaire, which focuses on obviously different functional elements that may, limit the ability of the elbow and the wrist and the hand. So my only critical analysis would be of these questionnaires is that it is very subjective, and that's what we know about pain and how we measure it, really. So there is no definite answer, if you say, to how much pain the patient really is in. So it's down to the patient more than anything. We can use these type of questionnaires at baseline, at 6 weeks and 12 weeks to measure the pain, whether the pain is subsiding and the function is improving. So, because we want to be able to return back to our patient's workplace and recreation as soon as we can. So, because he's already had 12 weeks off, so we want to make sure that this is actually working.
In 2013, Koeman et al. Investigated the use of a myofascial release technique on improving pain symptoms in those with chronic lateral epicondylitis. 30 participants were split up into 2 groups. The first group received only physiotherapy, and the second group received physiotherapy plus myofascial release techniques. After 4 weeks, Pain is described on the PTR-EE scale decreased in both groups. The greatest decrease was seen in the myofascial group with a decrease of 82%, whereas physiotherapy alone still had a good improvement of 47%. So another technique that has been used to try and decrease pain in those with lateral epicondylitis are mobilisations. Kamek et al. Split 40 individuals into two groups. The first would receive exercise alone, and the second would receive exercise along with mobilisation techniques. The results of this study showed that both groups improved their symptoms as reported by pain on the PTR-EE scale. However, it was the group that were prescribed exercise alone that improved the most, at around 140% after 3 months. The group that received exercise and mobilisation techniques only increased 30% in the same time period. So the results of this study indicate that mobilisation techniques are not effective in improving pain in those with lateral epicondylitis. Instead, Dave from Outrigger should have focused on exercise therapy to decrease his symptoms and hopefully get him back to work quicker than 10 weeks that he's been off for.
Strength is another element we need to consider throughout the whole process of rehabilitation, monitor it and measure the outcomes to make sure the patient is where he needs to be in terms of his goals for strength to return back to work, to recreation and daily living activities. Nicodelis et al. 2021 explored the validity and reliability of two hand grip dynamometers, the K-Force grip and the JMAR. The K-Force grip is a form of dynamometer used to evaluate and rehabilitate patients. It provides real-time biofeedback to a smartphone or tablet, and it sets goals and objectives for the patient and for the therapist itself. It's efficient in providing results quickly with testing and reporting done in 15 seconds. And also, if the patient is interested, they can provide interactive games based on the variations of force levels needed. The therapist can track these results through an interactive database, and the results show that this is a reliable method of use when compared to other dynamometers such as JMAR, especially in pain groups where pain did inhibit strength, and this research was done specifically in subacromial pain. So it might be hard to relate it to our patient with more lateral epicondylitis because it's a little bit different. So in the JMAR dynamometer, it carries similar properties in terms of use. It is used very regularly in practice, and it shows equal reliability of the K-Force grip and the JMAR. The JMAR nowadays can come with smart functions similar to the K-Force one, but it can be a bit more pricey, and the dynamometer itself can be a bit more heavier as well. Further to this, positions for optimal results was explored as well. Romero et al. 2010 explored elbow positions, how that affects the hand grip strength in adolescents using the JMAR dynamometer. They completed the test of the elbow extended and the forearm in neutral while standing up, and then the elbow flexed at 90 degrees. The hand grip strength did not significantly differ between the different elbow positions when the test was performed with the JMAR or any other dynamometers. And this was in agreement with studies in young adults. So they proposed that you can use whatever positioning on the grip. However, more recently, Cook et al. 2021 investigated how the upper limb position affects pain-free grip strength in individuals with lateral elbow tendinopathy. This study shows that pain-free grip force was higher when patients performed with forearm neutral in supination or pronation, elbow flexed, and the shoulder in neutral than any other test positions. This kind of suggests that if the patient is experiencing more pain than usual and you want to get their optimum performance in the strength, it might be worth using a flex position, and this would be a bit more suitable and reliable because it causes less co-contraction of the wrist.
Many studies have been conducted trying to investigate the most efficient way to improve hand grip strength. One of these studies was conducted by Kuhlman et al. In 2013, who investigated conventional therapy plus myofascial release against just conventional therapy alone. The results of the study showed that hand grip strength improved for both groups, but greater improvements were seen in the myofascial release group, with an improvement of 43%. So the study that was done by Kamek et al. In 2013 on mobilizations also investigated hand grip strength. The results of their study found that after 3 months, hand grip strength improved by 20% in the mobilization group and only 3.7% in exercise therapy alone. So a third study that looked at hand grip strength was the orthotic study done by Nwonti et al. In 2018. They found that the use of orthotics only improved hand grip strength by 1%, whereas physiotherapy alone actually improved it by 12%. So these results showed that hand grip strength can be improved at different stages of time and with different therapies. We know that Dave's been off work for at least 10 weeks now and has not attempted any therapy at all, so any improvements will be minimal. The reviewed literature points towards exercise therapy at least, with the smallest improvements being seen at 3.7%. The successful use of myofascial release can be explained by the technique speeding up the process of which fascial tissue returns to its normal length due to collagen being able to become reorganized.
An interesting study that I found to demonstrate different measurements for the elbow was by Cages et al. 2018, where they measured validity and reliability of the elbow range of motion measurements, such as photographs, movies, and goniometra's smartphone application against the universally used goniometers. So the handout that we've provided has a reference to how to measure the elbow range of motion and the wrist range of motion with the goniometer, so that'll be a good reference points for you guys. Results of the study found that photography and movie-based goniometry showed better validity in flexion and extension, whereas a smartphone applicator showed better validity for pronation and supination. The reliability for the photo and the movie was excellent, but quite poor and to moderate was the universally used goniometer and the smartphone application. The reliability of photographs is in line with other researchers, which found very similar findings. But there is very little evidence for movie-based measurements for the elbow from other researchers, so this is still an area of exploration. So what this research implies is that the standard goniometer that we see used very regularly may be less so reliable for unexperienced users. So may need other ways to find more accurate readings, such as what they've suggested is the photo and the movie, which is quite good. In regards to our trigger, it is most likely that therapists will be using a goniometer as a standard baseline check for the wrist and elbow due to many costs in the NHS, and I can imagine the photo and the video is quite expensive to have to do. So we can measure the range of motion of the wrist and the elbow at baseline, 6 weeks and 12 weeks, in line with the framework, just to make sure that we are on track to achieving those goals specific for the patient.
In 2016, Hassan et al. Investigated 2 separate techniques, both with the aim of improving range of motion at the wrist following lateral epicondylitis. 40 participants would be split up into 2 groups. Both groups would receive a conventional physiotherapy program. However, the first group would also receive a deep friction massage technique, and the second group would receive a program that focused on stretching the wrist extensor muscles. After 4 weeks, the results showed that the stretching of the wrist extensors was far superior in improving wrist range of motion in both flexion and extension compared to the deep friction massage group. For wrist flexion, deep friction massage saw improvements around 16.1%, whereas the stretching group saw improvements of around 21% in wrist flexion. Similar results were also seen for wrist extension. The deep friction group improved at around 30%, whereas the stretch group improved at around 38%. These results lead to the conclusion that Dave may not have needed to stay at home for 10 weeks. If he'd incorporated some of these into his rehab, then he'd have got back to work at a much quicker rate.